So thank you for inviting me to this great conference really, and it's about sharing and learning and going from today to see what can we do, how can we work with the people you live next door to, people who you come into contact with. Most importantly, how do we share and share the pain and share the journeys together. I think that's what today is about. But for me, I'm not a lecturer, I don't work in the university, I don't have a PhD. My PhD is personal health direct experiences, lived experiences. That's my PhD. But most importantly, my background is, again, I was born in Kenya. I was 6 months when I came to this country. My parents are from India, so I've been brought up in the UK, in Leicester. I live in Leicester. Family of 10, so we all came in 1969, so we're 69. We came in, all 10 of us, to Leicester in 69, in November, very cold. My father was a hairdresser. My mother was she did cleaning at that time, obviously in 69. So that was, so the life that, what they brought, obviously we can respect what they went through for us, the sacrifices they made for us. So that's how we've kind of come together. That's why the work I started off in my earlier career, I was a drug and alcohol worker. And my father used to tell everyone, I'm a pharmacist. And I said, I'm not a pharmacist, I'm a drug educator, I'm a social worker. He said, no, you deal with medication, you deal with drugs. But it was about, it's about people have these aspirations for all of their families to be in high-paid jobs, doctors, my sister's a nurse, my brother an accountant, but obviously I kind of felt it was important to be the social worker, youth worker. That was my passion. So today I'm going to be talking more around giving you some tips and some strategies, but sharing you how I've managed to address health inequalities from where I saw the gaps and the barriers. So, as I said, I've told you what my earlier career was. I became a type 2 diabetic in 2010. So I looked around and looked at what culturally sensitive, dietary information was there. Bearing in mind, I was a carer for my mum who was 40 years insulin dependent. So I knew about diabetes, but obviously working long hours, and working in, I've been working in race equality work for the last 35 years, and my interest, was going to look at culturally sensitive, culturally appropriate, information. So I looked around, and these diabetes programs wasn't culturally sensitive. So I went to India and got all the cookery books, got all the information, and shared them. But I thought, why am I going to keep it myself? So I set up the South Asian Diabetes Support Group. So that was the kind of initial focus and working with Diabetes UK, that was the key to do that, because you can't, when you start setting things in an isolated way for one community, people, even though it's legitimate, because in Leicester, if we look at Leicester's South Asian population, it was needed. So that was kind of why I did it. But it wasn't the reason why South Asian Health Action was born. It was born because of, I was been asked to work with 2 hospitals around the theme of organ donation. And the hospitals had organ donation committees, but they didn't have the links to the community. And recognising it in Derby at the time when I was running the Race Equality Council there, high Pakistani population, but the hospitals, despite having the clinicians, didn't have the networks in the community. So they said, Kirit, we're going to commission the university, can you be the community person to help us develop this project? I said, well, I'm happy to do that, but I'm coming in from a lived experience, so I want to recruit those ambassadors, those people who had the lived experience of being a recipient waiting for a transplant, or being a kidney, somebody who donated to a family member, living kidney donation, or somebody who lost a loved one because they couldn't get the transplant, or somebody who decided to donate. So I said, that's the kind of what I'm going to do. But it was, through the community networks, I found a businessman who had a heart transplant from the Pakistani community, and he ran he was an influential businessman in the city. And I thought, jackpot, he was the person who then, I went to him and said, look, well, we need to do some work in the Pakistani community, but other communities as well. And then after 4 years of community engagement work with this project, then we took to Leicester as well. So So I had 25 ambassadors in Leicester, 25 in Derby. What the hospitals do, they just have to kill the project off.
Oh.
So I thought, well, I've got these 50 people who are passionate, really, you know, they're the right people to go out there, you know. So I said, sod you, I'll set up South Asian Health Action. And that's what we did. We set up South Asian Health Action as a patient carer, community-led charity. It's been going 5 years. And we've kind of grown it on the basis that we don't have many paid staff. We're all volunteers, but we have ambassadors, and that's how we kind of prime our work around ambassadors. It's about to get your voices heard. The message today for me is to ensure how you get your voices heard, how you challenge those organisations, how you keep the doors down if they're not going to open for you. So I've had to kind of, learn the hard way. I've had to, set up the organisation, set up the South Asian group, but I had to go to the local NHS to say, where's your patient voice in diabetes? You're making decisions on our behalf, where's your patient voice? Kirit, we don't have one. Okay, 5 years on, I've been on that group to actually be the voice. But then I realised I needed to learn about kidney transplant. I needed to learn about how the kidney organisations work. So I became a volunteer for Kidney Research UK, just to kind of learn about their ambassador program so I could then support the ambassador I'm supporting. But then that wasn't good enough. I thought, no, I needed to learn about the stem cells. So I went, became a volunteer with Delete Blood Cancer, to starting to do stem cell drives. And then again, but that wasn't enough. Then NHS Blood and Transplant, who are the national body, I was challenging them. I took up the role as the co-chair of the National BME Transplant Alliance, because all these ambassadors I mentioned to you, right? They had the case studies, but they weren't being profiled in the media. They weren't engaged properly. And I said, why are your case studies not very diverse? They said, Kirit, because it's data protection. We don't have all these contact people don't come forward. I said, sod you, I'll develop my own case bank of case studies. I'll go to the media myself, and those who wanted to share their story, we will do that. So that's how I started to kind of get involved in all these organisations. But the reason was to ensure that we get the voices into those organisations, into those institutions. Today my presentation is going to be very much briefly to share where I see gaps, and if nobody's filling them, I try and address them. I told you I worked as a drug and alcohol worker, but I also worked managing mental health charity as well. So I kind of looked around, and throughout the pandemic, 2 years we were having challenge with a lot of issues around domestic abuse, a lot of issues around trauma, complex kind of needs. We kind of took on a contract with a women's organisation who were supporting women who have been trafficked through modern slavery. But our organisation didn't have the level of expertise to support these women and men. So I then decided, well, we've got the contract, but we need to give them a quality, culturally sensitive service. So I went through all these BACP websites, I went through all these counselling websites, and then actually found people who's from that cultural background, spoke the language, vetted them, did an interview, and said, right, we can offer you we need you to provide counselling support to these people that we're working with. But that's because I wanted to ensure that they get somebody who can, they've already gone through the experience of being trafficked, they've been going through trauma, they've got a lot of complex needs. And the last thing I wanted was, our standard, no disrespect to people who are, trained in psychology and counselling, but if you've got to be able to have that breadth of experience, be able to understand the complex elements of it. And if people claim to be, some of the counsellors I was working with said, Kirit, what are you telling me for? I'm BACP accredited, you're not. I said, listen, accreditation, you're great, you've got the accreditation, but can you show me your CV? Can you show me the cases you've worked with? And they realised that by bringing these experienced counselling, at the first time they saw there was a threat, but then they realised that why we were doing it, because we wanted to ensure these women and men got the quality support they needed. So I'm going to talk about the Ambassadors Project, which is really, and then some of the other work that we do. But the key thing, I'm going to leave you some tips at the end. I've told you we work on listening and understanding and advocating the needs of South Asian communities. But what I'm talking about today can be applicable to the communities you work. So whether, depending on the community you're from, the strategies, the tools, the challenges, the barriers are kind of applicable as well. You know, maybe it's a communication, language barrier, maybe it's not getting a culture-sensitive service, or maybe it's you need some gender support specific service. So some of these things could be applied to your kind of learning. But before I go on, can I just check who's in the room? How many people are community workers? If you already have, how many people are working in the health field? Okay, great. How many people working in the university or have students? Great, okay. And if I've missed anyone, how many people working for fire service, police, police? Excellent. So yeah, so the kind of, and who have I missed out? Any people from the community organisations in the room? No?
Young Person's Charity, but with the
Okay.
community organisation.
Brilliant. So I'm a fan of ambassadors, as I've explained, the need for people to be the right messengers. So we've got diabetes ambassadors now, we've got our community ambassador for organ donation, mental health ambassadors, but we now change the word from mental health to well-being because of the stigma and all those kind of challenges we have in our communities. But we, being a patient care-led organisation, we have medical advisors now we have people from psychiatry, from renal, and they're the ones who protect us because we can advocate but we don't advise. We work around these issues, but I'm not going to go into these. But our kind of vision is and work is around engagement. So we start off with the engagement to create the kind of discussion within the community to facilitate that. The attitude. We have to shift the attitude and the behaviour around the conditions that we have, how better to manage them. But it's no point just engaging. We need to educate them with the information and tools to kind of then make those informed choices. Then we realise that, okay, well, we need to empower them to take that back. We need to go back to their families, to their communities, and look at what other support do they need. And finally, one of the key things that we were missing out on was exploring was that research organisations were, was clinical. We weren't being engaged in clinical studies, in research. So I said, okay, well, why are you not engaging us? I'm a diabetic. How come I'm not being asked to go on these various trials? And we were finding that, and one of the roles I've just taken on now is for the National Institute for Health Research on their new Centre for Engagement and Dissemination, again to get more people involved in research. So that's about exploring research, but exploring opportunities as well. So we looked at how, in the pandemic, a lot of the family members, communities couldn't see each other, so they were given, some of them who could afford, giving them smartphones, tablets, etc. But they didn't have to use them. So we kind of luckily found a trainer in India who speaks Gujarati. That's the common language that we needed. And for the last 2 years, we've been running workshops every Saturday for 2 hours, empowering them to use their iPhone, their Android, look at how to get on Zoom, look at the other platforms, how to translate a letter through Google Translate, and then take functions. But the idea was that to empower them to be self-reliant and not rely on people some family members, because sometimes they can't be there to come and switch their Zoom on for them. So this has been, to address the digital exclusion, but from a culturally linguistic way, and that kind of, and we targeted predominantly the 50s and overs, but there was a lot of younger people who were saying, I don't know how to use these phones, so we started mixed people and started with 100 people, 50 we started off, and then I had to keep extending the Zoom to 500 because we just got more and more people interested. We were fortunate that we had this Professor Nandini, who's a local consultant in the services in Leicester. She was training on the mental health gap program, which the World Health Organization developed for predominantly low and middle income countries like Africa or India, where there's no mental health infrastructure as such. So they wanted to kind of equip lay people or community workers to understand about different mental health diagnosis, conditions, but most importantly, how to create conversations around mental health and stigma within the community. So I thought, well, we couldn't afford, as a small charity, we couldn't afford the mental health first aid program to train all of our volunteers. So this was the next best thing to look at, training our volunteers, and that's what we've continued doing. She's an asset to us, which is really great. And what we did was we launched it during mental health, on World Mental Health Day, and that was the kind of way we continued. And now we get people calling us from all over to say, oh, we'd like to can you come and train some of our ambassadors, communities to be mental health aware, and how we can work and create conversations in the community. But our mental health ambassadors are really more there to be the face in the community, to look at actually providing that initial conversation support, and if they need access to further support, counselling, etc., they're actually hand-holding them into those services. So those services understand that they've got a big brother, big sister watching over them. They can't be throttling, they can't be saying, go there, go there, go there. We actually monitor that. So that's kind of what we started to look at. Some of the partnership projects, again, I'm one of these people where I see the gap. So I came across an organisation in India who called Gaia Life, and they've developed these self-care packages around mental health, around anxiety, around depression. Culturally sensitive. I thought, wow, why do I need to reinvent? This is ideally what we need to do. So, we said let's look at their packages. They've got a toolkit for well-being, and we've trained another batch of community workers to look at how to use those toolkits and how to understand and then use those self-care tools that they come into contact with. While they're waiting for any specialist support, they could be doing that, and maybe, hopefully, they may decide they don't need the specialist support because this is what they're being given through the toolkit, and the specialist support was not medically. It's more from they look at meditation, they look at music therapy, and they look at positive affirmations. So getting people to feel positive about themselves, and that's kind of what this wellbeing toolkit works with. And then again, because we've got this culturally sensitive diabetes program, we started work with other neighbouring cities who wanted to do something similar. I'm glad you mentioned radio because I thought I'm chasing my tail really. I was so how can I get the message more amplified? I'm sick and tired of sending messages to the NHS, to the doctors, to the GPs, to other organisations around the health programme that we do. And it was lucky that one of our EVA FM was East African Voice Association radio station was set up 10 years ago for the East African community. And they said, you're doing all this health work, and why don't you just come and do a health programme, a health breakfast show? So I started that 6 months ago. I had no experience of radio, but I thought, wow, I'm going to get my message of our charity, get message. So every programme I bring a clinician in, I bring somebody with lived experience to talk. So I forgot that this month is breast cancer month, so we're going to talk about different cancers. But the programme I really wanted to talk to you about today really is hopefully that you could, NHS have, really for this last 12 months, 18 months, we've had Black Lives Matter as has been mentioned, but health inequalities was we knew that from the COVID-19, the disparity, the people that were affected, mostly that we saw that people were dying were frontline doctors, nurses from the diverse communities. Patients who went into hospital, again, didn't come out because of. So this program, it's called Core 20+5. It explains the Core 20 is the most 20% deprived of national population, according to the identified by the Index of Multiple Deprivation. But then we've always known about that. We've known, if we look at the larger cities with high populated communities, we know what diabetes is and how it's affected. We know about cardiovascular. We know about cancer and all the conditions. But what's been missing is that it's them and us. You've got the institution, the hospitals, but not really working with the community or the patients to empower them to get their voices, to raise awareness in the community. So when I learned about this project, I used to go to all the national meetings, and then I looked around on Zoom and I thought, where's our local NHS they weren't there. So got back on the phone, I collared our leader, says, why are you not coming to these, sending anyone to these meetings? NHS is going to give you money. We need that money to be able to work with you as a small charity. We can work with you to do the prevention work, to get lived experience voices to be working with you. So it was just fortunate that we challenged them. We now have a great partnership with them. But the plus 5 is the 5 clinical areas. So the plus groups are really the ones from gypsy traveller communities and communities like learning disabilities, other kind of plus groups. But we realised that the 5 clinical areas where there's still lots of disparities in maternity, mental illness, respiratory, cancer, hypertension, and obviously added smoking now is all part of that. You can have these slides, but this is basically what the approach is. It's about system changes. It's about working on a local level. I'm not going to go because I want to give time for some questions at the end. I've told you about the plus groups as well. But as I said, I went to the meetings, and then in the first wave, there was 14 pilot sites across the country funded that, and I believe I'm not sure if Cumbria was one of the successful pilot sites, but again, at the end I've got some links that you can check in your local area. But Leicestershire and Rutland is our local NHS integrated care system now, care board. So we actually did the expression of interest together for this funding, and luckily we secured it on the grounds that we were going to work with 3 delivery partners. So us, Sharma is a women's organisation, and Equality Action is an equality-based organisation. So through us 3 delivery partners that were embedded in the expression of interest, we got the funding, and we're focusing on South Asian communities because of our population in Leicester and Rutland. But the key essence of this programme is about developing community connectors, people with lived experiences. So the reason why our organisations were asked to kind of be working with the NHS on this is because of the track record. So as you can see, we were asked to work with the NHS and National Voices on a long COVID project. And again, that was around capturing experiences of people from the South Asian community going through long COVID, and why are they still not being access to get referred to for rehabilitation support? Are they aware of the signs and symptoms? So we did a simple kind of banner and put leaflets to kind of get them to understand about the signs and symptoms, so they can feel they can reach out and go back to their GP to say, look, I'm going through these signs and symptoms, I need to referral. So that's kind of to raise awareness of that. Cancer and hypertension is, as I said, the 3 areas that we're going to be working on is respiratory cancer and hypertension. It's a bit wordy, but cancer, because we still see our communities are not being detected early enough. Also, we know that we need to do more empowerment work with our communities, particularly let's take women with breast cancer. But how do they check their breasts on a regular basis? What do they need to look for? So the cancer kind of area we're going to be looking at is breast cancer, bowel cancer, prostate, the ones that are key. Because we know that we've lost, just recently we've lost a number of people who ended up with stage 4 and then as a result of bowel cancer, young 40-year-old died because of them not being detected anymore. So that's going to be one of our key outcomes as part of that. But we've also luckily found people in our community. Finding out people in our community that actually are the ones with lived experiences. So I'm going to just move on. So what I want you to kind of leave you some tips is about. I want you to go and challenge. People keep telling us we're hard to reach. I turn it around. I said it's not us who's hard to reach. It's you, the institutions, right, are hard to reach, or you don't want to reach with us. Right. So please, when people are telling you, oh, these communities are hard to reach, challenge them, please, because tell them it's you, not us. We've got to accept that institutional racism is paramount, and we've got to start talking about that, and let's not shy away from it. If you want to get kind of active and share this and get your community to be active, right, you've got local NHS integrated care boards, the ICBs. Let's be active with them. They're the ones that now, you know, putting all the NHS together, so mental health trusts, hospitals, and obviously the public health. So they're the ones that you need to be knocking on their door if you want to start getting involved in some of the health and equalities work. Don't get invited. Don't wait to be invited. You can just knock on the doors or kick the doors. Be proactive. And finally, you know, some of us taking leadership roles, right? We've got to be clever in terms of not to be allowed to be used as tokens, right, or just ticking their boxes. We say, what's in it for us? We need, you know, the goodwill has run out. I say now to all these organisations, contact me, Kirit, can you work with us? Yeah, we'll work with you, but what funding are you bringing to us? Because the goodwill is gone. Anyway, I'm going to share, you know, these links, right, which will help you, because I don't want to come here and give you reams of stats and do a lecture on health and equalities, because I think it's important that there's a lot of links that you can do your own kind of awareness and contact these organisations. But again, our leaflet is on the desk at the top there, so you can take that, and if there's anything you want to do, then feel free to contact me as well. I'm going to stop there and give you some time for any questions as well.
Can I just check, can we put a link on the information post-conference to that information of yours?
Yeah, because I've just got them. These are the key health systems that people need to be aware of, and not many people know. And now, you know, if we some of these are public meetings, okay, you can't go physically, but you can go online and watch them.
Yeah.
And it's only by doing that, you know, I get more information, up-to-date information from going to these, watching these online, than going, when I contact the people involved, they don't want to give me information. Information is power, so I get more information and I fire it back to them. So yeah. So that's it really. So you can share those links by all means, and again.
So if you can get them to us, or just email whatever you want to do, we'll be sending emails out next week to everybody with links and things that anybody wants to share. Because some people couldn't get here due to illness and things, so whatever you want, people who couldn't come, and us who work here to know, yourself included being around the others, if you could give us links to either to your own website or to how to communicate.
I think the message today was more about you, if you're passionate. So finally, I'm going to finish by saying I work on I show you shared the E's, but I also have 3 P's, which is passion, patience, and perseverance, right? And then finally, the 3 C's for me is commitment, connecting, and working in collaboration. So I'm going to leave it at that.
Perfect. Can I just say, if anybody has a question for Kirit, you can catch him in the break. Thank you so much, Kirit and Lena. That has been absolutely fabulous.